There we go. So yeah, so the brain is made up of these three main components. You have your brain tissue, blood, and your CSF. The brain tissue is like all of the neurons, like your neuroglial cells, all of that intra and extracellular fluids that is not the blood. And that takes up about 80% of the brain compartment, or the head kind of skull compartment. And then you have the blood, which is about 10%, and your CSF, which is another 10%. So the pressure that's created between those three elements is what determines your intracranial pressure. So this whole idea of autoregulation, we went over it in last week when we talked about stroke. It's definitely something that's going to come up. It's definitely something that's going to come up on an exam. This idea that the brain can't store oxygen or glucose, so it needs that constant flow of blood coming in and out to bring it oxygen and then get rid of all the waste. And the idea that, you know, the autoregulation is what keeps that flow separate from what's going on in the body, from the systemic, like, blood pressure, right? So we don't want our intracranial pressure to go up when our systemic blood pressure goes up. We want everything to kind of stay the same. So, oh, I didn't finish this line. I'm not sure why, but you guys have it already. So I just want to go here. We talked about intracranial pressure. So a lot of this stuff is just like for you. So like this, I just like things visually sometimes, so you can just get an idea of what we're talking about. But it's nothing you have to memorize or get really insane about. So intracranial pressure, you will have to know this normal range for sure. Have that memorized. This should say 15. Sorry, I'll have to fix that before I send it to you guys. And really, we're not. As soon as it starts going above 15, that's when you're going to start worrying. But anything above 20 is very, very concerning. That's when things are going to start happening. We'll explain more later, but it's totally normal for your ICP to go up and down a little bit when you cough or when you're exercising or even when you sneeze, things like that. So that's an absolute. I actually had that question on one of my exams. Basically, you had to know that to answer the question. It was anyway. There are a bunch of factors that will affect your ICP other than coughing and straining. Your body blood pressure, cardiac function, abdominal and thoracic pressure, things like your body position and temperature. But these things shouldn't affect it too greatly unless there's something serious going on, right? So this Monroe-Kelly hypothesis is really important to know for the entire unit, but also for the exam. So basically, the total volume of the brain and blood and CSF within the skull is constant. So if the volume of one of those things increases, then another one needs to decrease to compensate in order for the ICP to remain the same, right? So it's really interesting that if you look here, because I was always like, well, how does that work? How does the brain tissue expand volume and so on? So the brain, for example, so say if there's an increase in blood flow to the brain, and so the volume of blood has increased, right? The very first method is going to be your CSF. It's going to compensate first. It's going to try to it'll decrease production and increase absorption, right? So that the CSF is being shunted away from the brain, not all of it, but some of it to relieve some of the pressure. And then it can be displaced into this cistern. You don't have to worry about that, but it can't do a whole lot, right? There's only so much CSF in your skull, I guess, or in those three components. And then the brain has a little bit of like ability to decrease. It can kind of, this dura mater can kind of, this dura layer here can kind of contract a little bit. So you can imagine like the CSF here and here has kind of shrunk down a little bit. Then this can kind of move in just a little bit. But you can imagine like there isn't a whole lot of room for things like an intracranial bleed, or just anything where that pressure is increasing. Yeah, I'm just going to keep going. So, but that's kind of how they make room. There's more stuff down here, but you don't need to worry right now. This is good for you guys to look at later too. But so let's talk about this idea of compliance. So this will come up for sure. Well, I shouldn't say for sure. How many questions, do you guys know how many questions your test will be for, like, because you have stroke, brain injury, and the 2 renals all on one test, right? Does anyone know how many questions that'll be? No? 40? 40. Okay, so for real, when you're going through this stuff, remember that 40 questions on all of this stuff. So they're not going to be able to ask you like super detailed stuff. Unfortunately, they do sometimes like pull up a really kind of feels like an obscure concept. But make sure you focus on the big things, because these are the things that they'll ask, likely something about compliance, knowing what it is. So the brain's ability to maintain its ICP really depends on how much the brain is able to change. Like these things over here that we just talked about, how able is the brain to kind of contract, and how able is the CSF to move, right? It's not a very, everybody has, like, even if you have good compliance, right, which means all of those things are able to contract and do their job, it's still only going to last so long, right? If you have really good compliance, a change in one of those volumes won't make too much of a difference, and it won't affect the ICP. But it can, like I said, it can only last kind of so far, right? So we want to get that under control as quickly as possible. But if you see a question that's talking about high compliance or low compliance, that's all it is the ability for the brain to kind of shift and compensate for what's happening and keep the ICP where it should be, right? So here's, I don't think we need to go. You guys, these are kind of the things that you know, what can make the system fail and the ICP rise like that, right? So you said they talked about concussions already. I don't know if you guys covered like subdural and epidural hematomas and hydrocephalus, tumors, abscess, hemorrhage, anything that's occupying any space in the brain. Those are all things that are threatening the ICP, right? I just want to see where we're going here. Okay. So this is where I think sometimes things get tricky. So your cerebral perfusion pressure is the pressure that is left over, or the pressure. So if you imagine that, let me start here. If you imagine that there's only a certain amount of pressure, let's say available kind of in the body. You have your mean arterial pressure, right? That's the average pressure in your body. We'll talk about that in a second. And then you have your intracranial pressure, right? Your cerebral perfusion pressure is kind of what's left over here. It's what's left, what's available to use to push necessary like oxygen and glucose and what have you into the brain. We'll talk about it again, so that even if that's confusing, we'll go over it. But how do we calculate CPP? This kind of gives you an idea, right? So it's your MAP minus your ICP, right? MAP is really important concept in the ER. A lot of times, like, we're just looking at MAP and not even necessarily looking at BP. And that's because it gives you the average pressure in the arteries over one cardiac cycle. So the heart contracts, pushes the blood out, the heart releases, and everything relaxes, and the heart's filling again. That's one cycle. So the average pressure in all of that should be somewhere between 70 and 100. Right? And we talked about what ICP is, right? This is the pressure in the cranium or in the skull. This is what we need to keep under 20. The normal we said was 0 to or 3 to 15. You shouldn't have 0, but. And then again, we talked about how much, CPP being how much pressure then is available to perfuse the brain. Yep, I see. So the higher any pressure other than CPP is, the less. Kind of, Darla. So Darla's asking if the higher pressure in any of the others means that the CP would, the less the CPP pressure would be. If you mean the higher the MAP and the higher the ICP, let's go through that actually, because it's a little bit complicated. I drew this like thing here because it isn't necessarily the higher, right? So if your cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure. It's what's in between those two things, okay? You're right in that if your intracranial pressure starts to rise, say it's here now, then your cerebral perfusion pressure is going to be less. There's less between these two things. But if your MAP rises, right, it's actually, in this case, almost a good thing because it's creating that room again for the CPP to be normal. What's actually what we don't want to see happen, and what usually does happen, is that your intracranial pressure will start going up like this, right? And your mean arterial, what we don't want to see is your mean arterial pressure going down, right? Because then that's actually, it's diminishing all the pressure in the body, right? Because your mean arterial pressure is kind of the average pressure. So it just kind of makes sense that that would also affect what's available, what pressure is available to go to the brain, right? So you'll actually see, the first time I saw this in the ER, I was like, what are we doing? And I had to kind of think back to, and I mean, I was still a student at the time, so it was fine. I could ask questions, but somebody comes in and they have a head, whatever. We don't actually want their blood pressure or their MAP to drop below something. So if they come in and their blood pressure is, I don't know, 165 over something, it's actually okay to leave it there for a little bit. We don't want to, give them something to bring their blood pressure down at that point, because it's actually going to give less pressure. You're going to have less pressure available to perfuse the brain. So really this is what pressure is available to perfuse the brain, right? So I don't know if this helps, Darla. If not, I can explain it a different way. But if that makes sense, okay, good. So that's a little bit tricky, and those questions definitely come up on the exam, like what's important, what should you do, kind of thing. But if you understand those relationships, you should be able to answer the questions fairly easily. Make sure you know these norms, right? Your mean arterial pressure 70 to 100 is normal, and that makes sense, right? Think about if your pressure is 120 over 80, and then it's 130 over 80, and then it's, if you think about kind of what's going on in the body, 70 to 100 millimeter, or this actually makes a whole lot of sense. Millimeters of mercury, sorry. So I just want to go over here just so that let's keep going here. So how do we control those things, right? Just so you know, how do we control the mean arterial pressure? It's the same way we control blood pressure, right? We're going to use antihypertensives. And like I just said, we're not often going to want to be bringing the blood pressure down in a case of a head trauma, but fluids would, if we give fluids, that would bring it up. Diuretics would bring it down. Giving blood and plasma, again, would bring it up. And then your ICP, we talked about what's it controlled by. It's controlled by those three aspects, and we can actually change the pressure in the brain from the outside. Like we can actually control it a little bit using mannitol or hypertonic solutions, meaning we can pull some of the extracellular fluid. We'll talk about this later, but pull some of the extracellular fluid out of that brain tissue so that the brain kind of essentially gets smaller to relieve some of that pressure, right? So sorry. So your normals are here. You guys can, I'm sure, you just have to memorize that. That's not a whole, there's not a whole lot else that we can do. So this mean arterial pressure, if you understand the concept of it, then just think about this. You don't have to actually answer me, but what do you think would happen then to the brain if the map went below 50? Like if it was very low, right? Kind of think that through in your head. If your arterial pressure is low, that means your central perfusion pressure is going to be low as well, right? You can either think of it this way, or you can just think of it logically. Your cerebral perfusion pressure comes from your overall body pressure, right? So if your MAP is low, your CPP is low, the brain isn't going to get enough blood, right? So you're actually going to see some ischemia if it's very, very low like that. And that's kind of what we want to avoid happening. We don't want this cerebral perfusion pressure getting so low that it's unable to perfuse the brain properly. So, sorry, I just want to make sure I'm not missing little things that you guys need to know for the exam. So if you understand all of this stuff that we just kind of went through, you're laughing because the rest of it is just kind of, I feel like it makes sense, the rest of it. So again, when your intracranial pressure rises, we have to the only way we can control that is by controlling the mean arterial pressure to make sure that the brain is still being adequately perfused. So these are your normals. Again, I've put them all over the place, so you'll see them so many times that hopefully you're not going to really even have to try to memorize them. You're just going to be so used to them by looking at them. So again, we don't want our CPP going, I would say 50, 40, whatever, millimeters of mercury. Sorry, I don't know why I'm having a hard time with that today, because we're going to be ischemic. Yeah. So what can cause that, right? What makes that happen? Any kind of structural damage to the head, open or closed wounds. You said you guys talked about, concussions. There is a type of concussion that definitely, or this contra-coup will come up. We'll go over that. So maybe kind of know these two categories of head injury. You can have this initial injury or the primary injury, and that's just the actual thing that happens. You get hit in the head with a baseball. That's the primary injury. You fall and hit your head. That's the primary injury. You have a stroke. That's the primary injury. Okay, so like the actual thing that's happening. And then the secondary injury is like something that's happening because of that. That usually happens a little bit later. For example, you guys know from your first semester that when there is an injury and there's cellular damage, you're going to have an inflammatory response, right? So that's going to happen fairly quickly, and then depending on how bad the injury is and whether you treat it, it could take a while, but you will have possibly that edema, maybe a slow bleed that is a result of that initial injury. If your ICP starts to go up, intracranial pressure starts to go up, your CPP is going to go down, right? And so if you need to look over here again, go ahead and kind of think about that. But your ICP is going up, your cerebral perfusion pressure is going down, so now you are hypoxic or ischemic. So anything that kind of happens as a result of that initial injury is going to be your secondary injury. It's not like a super difficult concept. I know you guys can get that. These like highest, this might come up on the exam. So your highest risk of death resulting from this, like from this traumatic brain injury, it's most likely to happen in one of these 3 points in time. So immediately after the injury, you've seen that happen on TV, right? Where people get hit in the head and that's it, they're done. Within 2 hours of the injury, and that's usually because of this edema and this like things that are happening slowly as a result of that injury. And 3 weeks after the injury is often just how long it's taken either this slow bleed or say a hematoma to form and increase the intracranial pressure to the point where the CPP goes down enough that we're not getting pressure. That's why we worry, if any of you watch Grey's Anatomy or any of those shows, when they talk about getting hit in the head and then, you know, like they'll be in Emerge with their friend and then all of a sudden they go down like an hour later, 2 hours later. It's this kind of thing that they're talking about. So I'm going to just talk about this coup contra coup really quickly. So this is just a specific type of injury or damage that occurs when the brain kind of moves around or bounces around in the skull. So the initial injury, I think this is like, say, a wall or something. Your initial injury is when the brain right here hits the skull here, but it's gone so hard that it actually bounces back after and hits the back. So you end up with 2 kind of sites of injury right here and right here. So your first hit is called coup, and then the second hit is the contra coup. These often will result in a concussion. So I think I did concussion right after that. It's possible, maybe not. So we talked last week about this excitotoxic reaction. Remember we talked about the glutamate and how that whole cascade, that ischemic cascade. Really, you could have something very, very similar happen here when you get injury. You have that injury to those neurons, that same way we did last time, right? And then you have that overstimulation of the glutamates. The calcium flies into the cells, and eventually, you know, you have that whole ischemic cascade happening, and then eventually cell death will occur. At the same time, you're having that inflammatory response, right? Your cerebral edema or swelling, right? That's just the inflammatory response. Your blood and CSF, again, are going to try to compensate, right? And to keep the ICP correct. But at some point, your ability to, we talked about over here, to your compliance, right? Even if you have very, very high compliance, at some point, it's going to give out. And these are just kind of like your CSF has tried, your blood flow has now been reduced, and now what happens is your brain tissue will actually start to compress and push down into the brain stem. So the pressure becomes so much that the brain is starting to herniate down this way, right? When this happens, I don't know if she talked about this diffuse axonal injury. If not, I'll skip it. Darla, do you remember her talking about this? Oh, I gotta flip back so I can see. Yes, cruddy. Okay. So this one is really hard to organize, and I went through your prof's slides and she organized them fairly well, and I was like, okay, but it was a different way that I think, so then I tried to organize it my way. So it is, hopefully this is helping, but it's a little bit all over the place, because we just talked about what's going to happen. We talked about this herniation, right? So we can go all the way and start talking about all these herniations, but I think let's focus on this for right now. So your diffuse axonal injury, this happens a lot with coop contra-coop injuries because it happens as a result of that rapid acceleration and deceleration of the head. It creates these kind of shearing forces that actually damage the axon, right? So this is when people go into a coma, like within 12 to 24 hours after the injury. They might seem okay, and then they will go like so quickly, a decreased level of consciousness because of your increase in ICP. You might have some of this decorticate and decerebate posturing, which we'll talk about later. And basically we'll go very quickly into a coma, and a lot of people do not ever come out of that. So I'm trying to decide, let's go this way. Since I don't know how much we covered of this, but your concussion oftentimes, very often, results from that coop contra coop injury, but it can also, we've all seen or experienced, I keep saying baseball because that's happened to me, where you get hit in the head with a baseball and then you end up with that concussion, right? So with concussion, you may or may not lose consciousness. There is usually, because you can have like a mild concussion, a medium kind of concussion, and then like a more severe concussion, right? With the mild one, you may or may not lose consciousness. There's usually not any lasting damage. You won't see anything showing up on the CT scan. It's just one of those cases where your doctor says, okay, go home and we'll do another scan like in a week, or everything's kind of, there's nothing on imaging, so it should kind of heal up on its own. But then you could have a more moderate concussion where there actually is an amount of bleeding and swelling that will show up on a CT scan, and you may have some like outward manifestations of that, like hemiparesis or aphasia or some kind of like palsy. And that's, I mean, those things actually, I find when it comes to concussion, that's a little bit easier to, when you can see it like that, like you can see something is happening. It's the ones where the patients come in and they've hit their head, they haven't lost consciousness, that those make me nervous, just because you have to get imaging to know what's going on, right? And then of course you can have a very severe concussion where it's basically irreversible, and there's huge like neurological deficits, and you could end up in a coma or like hemiplegia or some other. This, I don't know if you need to know about post-concussion syndrome. I know that came up on one of my exams, and I was like, what? It's just this kind of like 10 to 15% of people will experience like headaches and irritability, like insomnia, poor concentration, poor memory, and that can last for a couple of days after the original injury, that primary injury, or it could last up to a year after that primary injury. But you could have a little bit of memory loss. I think they call it like anterograde amnesia. So this is something that it actually happens more often than some of these other things that we've been talking about, where you have a couple of days of like, your concentration is really poor and your memory is kind of down. This actually happened to me right before I had to write a huge, I don't know if you guys did OSCEs, but we had to do OSCEs where it was just a huge exam and you weren't allowed to fail, or you were basically out of the program. It was back in RPN school. And I had a concussion. So it was quite difficult to concentrate, I will say. Never really experienced that before. And then, so the difference between, so a lot of people will get these two things kind of mixed up. That's why I put them side by side. So concussion is everything that we were just talking about. But a contusion is basically a bruise on the brain. And you've always heard of bruising as, well, isn't that kind of a hematoma, right? It's not necessarily like one giant hematoma, because that would be a hematoma that we'll look at later. This can happen. It's more like thousands of little tiny hematomas that causes it's a bruise, right, on the brain. And then again, prognosis will just depend on how many of those there are, how much, how affected it really is. So I did want to go through this stuff with you. This is the stuff that tends to show up on exams, that because we've talked about kind of the patho and what's behind it, but what do you actually see on the outside, right? This is the stuff that tends to show up in people maybe haven't used a Glasgow Coma scale. So I just wanted to go through it with you so you kind of know what it is. Has anybody done one of these on patients, a Glasgow Coma scale? Because you guys have placements and stuff, right? But no one's got any head injury one, I see. So this is like kind of the number one base like assessment when somebody comes in with any kind of head injury at all. And in fact, I've had days where I've gone in, so I used to work on the units quite a bit more, and you go in and you'd see a patient that yesterday was talking normally and everything was fine, and then you go in the next day and they're kind of sluggish, and that's where immediately you're going to need to have a Glasgow Coma number kind of to give the physician, like they've gone from a 14 yesterday to, maybe a 12 right now or something. So they know there's a big difference, right? Glasgow Coma scale is the way we empirically measure kind of this abstract level of consciousness, right? So I find this question will come up where they'll tell you, okay, the patient is able to respond when you talk to them, their eyes are open, but they're not able to do this or they're able to do that. And then you're supposed to pick out the Glasgow Coma scale, like what their number would be. And usually it's just like, would it be between 3 and 8 or 13 and 15? You don't have to know the exact number, but just have an idea of how this works. So if they're opening their eyes spontaneously, like on their own, good morning, they open their eyes, or if they open their eyes just when you talk to them. Sometimes you'll have to do a sternal rub or something to get them to even react. Their eyes are not open at all. So we don't just go around like pinching our patients. There are specific things like a sternal rub that we do. And then obviously none is really bad. And you can see over here, you get a score for each of those things. Your verbal response, this is where you do your orientation, right? You ask them if they know where they are, what their name is, what the date is, see if they're oriented to time, place, and person. If they are, they get the full score. If they seem confused or disoriented, they get one less. This distinction between inappropriate words, so they're not just confused, they're just not even using words that like match what you're saying at all, right? And then you get to the point where they're not even making words at all, they're just kind of groaning and making sounds that are not words, and then again, none, right? So it goes down for each one. Pretty simple. Your motor response, this is where you ask them to grip your hand or what have you. And this is what's really good is if you're doing a neuro check, you're already doing some of this anyway in terms of if you're checking for signs of a stroke, for example, you can have them lift their arms and squeeze your hands because you want to see if there's any kind of one-sided weakness, right? So you're kind of doing this all at the same time. Do they obey that command? Great, then they get a 6. And it goes down from there, right? Sometimes they'll only respond to localized pain. Sometimes they won't quite respond to the pain, but they'll pull right back from the pain. And then you have this decorticate and decerebate posturing, which we'll talk about later. And again, it's just going down So all you really need to understand, 13 to 15 is, I mean, 15 is normal, right? So 13 to 15, you might have a mild injury. We're not super worried. We just keep an eye on you. 9 to 12 would be more of a moderate injury. And then if you have a Glasgow Coma score below 8, this indicates some fairly major trauma to the brain. Anything really below 8, you really want to worry, right? And start to well, for us, we immediately call the physician, call them, the most responsible or what have you. So if you get confused about that, all of that's kind of written down here for you, so you can kind of take a look. You don't have to memorize this stuff. Just kind of have an idea of what these scores, kind of what they mean in general, in case a GCS question comes up. I find those do come up quite often in the exams. So your prof didn't go through, Darla, maybe you can help me here. They didn't go through all the brain herniations, right? Like the different kinds of brain herniations. Because then we don't have to go through that either. Just what a herniation is. Perfect. Because there's this whole, like, all these different kinds of herniation. So don't worry about that when you're studying, okay? I just didn't know if you had to know it or not. So let's go down. If I start talking about something that you don't need to know, can you just let me know, Darla? Because some of the stuff was just, I know you have to know like everything that's in the textbook technically, but I don't want to cover more than you need. So yes. Awesome. So hematoma, we know, or we're learning, I guess, right now, that is a collection of blood that builds up in the brain or in the intracranial space, and it can grow like under the dural lining, kind of here, right? So if it's under, we call it subdural, so subdural hematoma. Intracerebral is just what it sounds like. It's in the cerebrum, right? So bleed right in the one or both hemispheres of the brain. And then you could have an epidural hematoma where it's kind of above the dura, but if you look at this right here, actually there's a better, you probably don't need to know all the different ones, do you? You just need to know like what it is. I'm going too far as usual. Anyway, I put the names here in case you need to know them. Please don't go crazy if your prof didn't just sub an epi. Okay, perfect. So maybe just go through these two. An epidural, again, it's top of the dura. So again, you can see that right here is between the dura and the skull, right? So I don't know about memorizing like these things. I used to go crazy memorizing all these things. They never showed up. Oh, is Kieran here?
Yeah, I'm here.
Oh, hi. I didn't know if you were here or not. Okay.
I think for you.
No. There's quite a lot of content. Like you guys had to do all of this last year.
Yeah, we needed to know. Yeah, I remember knowing that. But the chart that you just gave right now, you were going over about the hematomas, that's really good. I think that's really done really well because I remember knowing the symptoms for those. But yeah, I think those 4 are fine to know.
Yeah.
They didn't go much in depth about that on the exam because again, it's only 40 questions. They didn't have that much time. I would say the Glasgow Coma scale is really important to know. I remember our professor saying lower than 8, you intubate. That's how I remembered it.
Right. Yeah.
And yeah, so yeah.
Okay, good. Okay, good. Because I know the exam obviously will have changed over the semester, but it's actually like different content this time around. So I just don't want to overdo it. I don't want to, but that's good. Then Kieran's saying have this kind of know these. And again, if you can break down the words, right, you know that sub means under or beneath, and dural is dura, right? So you should be able to kind of put that together. That's not super difficult. And then pretty much for all of the hematomas, I mean, even the intracerebral, even though it's kind of not here, you're going to have all of these kind of symptoms. It's all about your level of consciousness. Really, it's a lot about this Glasgow Coma scale and your level of consciousness, right? You're going to have a change in the level of consciousness. You're going to have, at the beginning, a headache, and then eventually, once the hematoma gets big enough and the intracranial pressure has changed enough that now your CPP is low and you're not getting perfused, that's going to happen fairly quickly from when you feel that headache, right? Because you're only going to start feeling that headache when the intracranial pressure starts going up. And when it gets to a certain point, you start to feel that headache. Unfortunately, when it gets to that point, your CPP is low enough that you're very, very quickly going to go from like a kind of 13 on a GCS right down to an 8 or lower. And that's why we worry so much about these hematomas, and why when somebody comes in and we say they hit their head or what have you, even if they have no symptoms in the moment, you're almost always going to do some kind of scan. You want to make sure that they don't have a slow bleed or a hematoma that's basically from a slow bleed, right? This kind of the onset is really, really important to know, right? Like knowing the difference between all of the little symptoms, I don't think is as important as understanding that the level of consciousness is what's really going to change. Your GCS is what's really, really important. Knowing that you're going to have an ipsilateral pupil dilation if you have an epidural, and then drowsy, confused headache weeks later. Like, I wouldn't, Kieran, maybe I'm wrong, but I wouldn't worry crazy about this part of it. I would just worry about this.
You're right. Yeah.
Okay. Level of conscious.
Yeah, exactly.
Yeah. Don't go crazy memorizing that stuff. I spent so much time memorizing that stuff, and then I'd go in and I'd be like, oh, there's like half of what I studied.
Yeah, because there's so many other things in this, because it's such a big chapter. Like, there's so many other things that you should know other than like the nitty gritty. So
yeah, that level of consciousness in GCS is really, really what we're going to be doing as nurses, and being able to interpret that and perform a quick GCS is what's really, really important, right? So cerebral edema, you have, so this is kind of, we talked about hematoma, right? This is kind of another thing that can happen after a traumatic injury, where you can have this accumulation of food in the extravascular spaces of the brain tissue, okay? So this is like, you can see like a picture here of what that kind of swelling looks like, where the brain actually swells. And it increases in tissue volume. And we talked about, tissue, blood, and CSF are the three parts of that make up your ICP. So if your tissue goes up, then you need your CSF and your blood to go down, right? But we talked about these two things can only compensate so much before they're going to give right out. This accumulation of fluid, if you remember back, this is part of your inflammatory response. It can disrupt the BBB. You don't need to necessarily worry about that. That it peaks 24 to 72 hours later is kind of important, because again, this is something that you may not see right away, but it will come on more slowly. And we'll talk about what it looks like in a bit, but you can probably guess that it looks like a change in level of consciousness, right? All this brain stuff, it's just the level of consciousness is so, so important. So there are two, there are two that they want you to know for types of edema. You have this vasogenic and cytotoxic. So here you have like the cerebral capillaries become permeable, right? Your capillaries that are feeding into your brain, alters the blood-brain barrier, and then protein leaks into the extravascular space. And remember, we know that when protein leaks into the intravascular space, that's going to change either the osmotic pressure on the outside, or you can call it oncotic pressure. It doesn't matter. It's going to, regardless, when you have large proteins, it's going to pull the fluid. Wherever that protein is, it's going to pull the fluid toward it. It's probably hard to remember all that from when we did fluids and what have you. Oh, I put it right here. It pulls the fluid. This one happens in the white matter of the brain. So if you look here, I did like a little, just so you understand, right? Your white matter is kind of the deep part of the brain. Gray matter is kind of the stuff on the outside, on the edges, I guess. This vasogenic edema, it happens more often than the cytotoxic, occurs over a slow period of time, right? It's slowly building up. In cytotoxic, so sorry guys, so vasogenic, right? Vaso meaning it begins in the vein or the vessel. It's vasogenic. Genic is creation or beginning of, right? It begins in the veins or the vascular system. Cytotoxic edema has to do with the cells themselves. So the function of the cell membrane is disrupted by whatever that trauma was that happened. The fluid then shifts into the cells, right? Over here, they're shifting out of the cell. Over here, they're shifting into the cell. And again, it's happening in the gray matter, and you're going to get that kind of swell. All of those cells are going to swell up, right? But this one happens quite a bit, like more quickly, and is reversible. This is also, all of this is treatable. So let's go down and just talk about how we're going to actually, yeah, here's your manifestations. We'll talk about how we treat it in a second. Again, just like I said, the level of consciousness, really your big thing. So a change in any of the following, level of consciousness, speech, sight, pupillary response. So whenever you have a neuro, like a quick neuro, would always include like your orientation, your GCS, and then always your pupillary response. And actually, if you work on a neuro unit, they have a section where you have to put in, 2 millimeter brisk response, or 1 millimeter slow response, or whatever. You don't need to know that for this exam, but just knowing that the pupillary response can change. Cerebral edema often happens, again, it happens slowly, so it really is something you have to watch for. Yes, this is really important. You want to do your vitals often when someone is at risk for cerebral edema, because it can come on. It comes on very, very slowly and subtly, so you need to watch carefully for these. Anytime you have a head injury with nausea and vomiting, that's an indication that something more is going on. That's why they always ask you, did you throw up? Did you, what happened? Whenever you hit your head, right? It's an indication that something more serious is going on. You have this blurred or double vision. I broke down the word for you guys. You can look at that if you want. Because it will come up in an exam, diplopia. And people are like, what is that? So it's double vision, right? It's di meaning double, and oplia is vision. So it's just double vision. They're just trying to trick you up by using like the medical term for it. So somebody comes in, they've hit their head, they have all of these kind of manifestations, their level of consciousness is going down. We're very, very concerned. We do a scan, we see that they have edema, right? They have, let's say, vasogenic, because that's more common, where all of the brain tissue has started to swell. What do we do? So there are two kind of major ways that you can treat cerebral edema. You can use mannitol, or 3%, or sorry, this is a hypertonic solution, right? It's not normal saline, right? It's above. It's hypertonic, and we talked about all that, I guess. So if you look at this kind of little visual here, it's just a reminder. If this here is the interstitium, is where the fluid has built up, right? And this is the vessel, right? We put, let's say, a hypertonic solution into the blood, so it's got all of these I guess osmoles or whatever particles. It's got really it's sodium. All of these sodium is what it has. The body is going to try to dilute what's in here so that the ratio of sodium to fluid is the same as it is here. It's going to try to match it up. So it's going to pull all of that fluid out of this intravascular space, sorry, extravascular space, into the vascular space, into the blood, and then from there it will flush out. If you look here, it will flush out through the kidney. Mannitol, so that's basically what happens whether you have mannitol or normal or a hypertonic solution. But mannitol also has this added kind of perk or whatever, where it stops that sodium in water from being reabsorbed, so it's back into the system. So I mean, we can go through all of those responses, but we won't. That's just a general idea. Usually water comes into the nephron and, you know, does their whole thing, which Kieran's going to talk about next week. It's going to go through it in super detail. But the bottom line is we want to get rid of that fluid. We don't want it going back into the body. And so mannitol has this extra kind of thing where it doesn't allow it to go up. Just want to make sure there's no questions. Okay. Again, whenever you're giving something like this, so you've pulled all of that fluid out into the vein, that fluid has to go through the kidney, right? And either, for the most part, the kidney will reabsorb sodium and water and excrete potassium. That's kind of its thing. Sorry, Kieran, I'm jumping all over your lesson next week. But so because of that, even with the mannitol, you need to watch out for any signs of what's the word? Extra volume, whatever. Can't think of the word. You've got your like CHF or pulmonary edema, anything that there's too much fluid in the body, right? Because it may not all come out. Some of it may be reabsorbed, and then it could build up. They say it's like mannitol and a hypertonic solution is contradicted in a person who has renal disease, and you can see why, because of what we just talked about. In real life, like if somebody's this is more threatening. Sorry, the cerebral edema is more threatening in the moment, then most of the time they're just going to give it, because what else can you do, right? We'll worry about the kidneys after. Let me just see what else there was. Okay, so I don't want to miss this. Cerebral edema. Well, you guys didn't do the skull fractures. How did you guys talk about the different kinds of hemorrhages? Some of this I think was on your slides and some of it wasn't. You know that a hemorrhage is just basically a bleed in the brain, right? And you're going to have very similar symptoms to everything else that we talked about, change in level of consciousness and all of that. Those symptoms, I just want to make sure. These are really your intracerebral hemorrhage, which is the one that happens here, and your subdural, which is, we talked about where that is, right, under the dura. We talked a little bit about hemorrhages last week, so it's basically the same concept, the bleeding, and you're watching out for a change in level of consciousness. And again, this is somewhere where the blood in the space is going to, the volume of blood in that intracranial space is going to increase. So we need the brain tissue and the CSF to decrease, to decrease as much as possible to keep that intracranial pressure normal. And again, there's only so much that it can do. This was new-ish, this chronic traumatic encephalopathy. You've seen this before, where especially in like ex-football players or wrestling. My grandfather was like a professional boxer, and he had this. It's just basically like permanent damage to the brain. Cephal, again, this is always brain. And then pathy is always disease, right? Or dysfunction. So really it's caused by regular repetitive brain trauma. And it wouldn't be like brain trauma where you know, you're having a bleed or you're having, it's more like repeated mild or moderate concussions, right? Over and over and over again, you're getting these mild like hits to the brain. And really it comes out, it happens quite a bit later in life. So you may have all of these hits when you're 18 to 20, and then in your 30s, you'll start to see these kind of mood changes, again, headaches, memory problems. You know, those all have to do with your brain, right? You know, that's not going to be a problem with something else. You won't necessarily have that drop in level of consciousness here with this kind of slow degenerative problem, right? It's just going to be like a slow onset of these symptoms, headache, memory problems, and so on. There isn't a whole lot that they can do about that at this point. Sorry. Ooh. I know, sorry. My computer's a little bit frozen, so I apologize. This was good. I liked this. So this kind of broke down your like symptoms of a brain injury, and this can be pretty much any injury. So again, your number one is this loss of consciousness, or this lowered level of consciousness, this confusion and restlessness. You might have changes in a pupil size or in reactivity, so you flash the light and it's a very, very slow response. You may have a little bit of a slowdown in your respiratory rate. This is when you want to catch it. This is when you want to see something is coming and you want to do something about it now rather than wait until these kind of late signs happen. And again, you're going to keep decreasing in level of consciousness until you reach a stupor. Now, I put them somewhere. Sorry, this is being really slow and touchy. Sorry. Somewhere on here, I broke down what stupor is, what coma is, like the level. They go in order. So if you want to take a look for that, I know it's right here. So somebody is confused, they're disoriented, their cognition has gone low, their GCS is probably 13, 14, I wouldn't worry too much, right? But that could be the beginning of something happening. Delirious, they're disoriented, they might have hallucinations and delusions, so this is all kind of going down. Obtunded is like lethargy, but beyond lethargy. Like their GCS is still over 8, so they might be responding. They might move in response to you, but they're just so lethargic. Then you have this stupor, which point you're barely even conscious. Yeah, your GCS is going to be lower than 8 for sure, probably between 4 and 8, and then you have a coma, and you'll have that GCS of 3. So if any of these words come up, just kind of, I mean, especially these ones people struggle with, just make sure you know kind of what they mean, where the GCS is, so that you understand the word so you can answer the question. Anyway, so we've gone past these kind of early signs. We're in the place now of stupor, so they're barely conscious. Now we have bilateral and unilateral, possibly changes in the pupils. And then this changed Stokes respirations, which I'll talk about in a second. And your decorticate and decerebate posturing, and then, which I'll talk about, and then you're heading into a coma from there. Okay, so these are kind of the really important, other than you're lowering your level of consciousness, the other things to remember. This Cushing's triad is really, really important. These are your signs of increased intracranial pressure. It's called Cushing's triad, not to be confused with Cushing's disease. They are hypertension, bradycardia, and a widened pulse pressure. Your pulse pressure is the difference between your systolic and diastolic. So it's going to go from, I'll just go with 120/80 to, 140/80, 150/70, right? That pulse pressure is getting wider and wider. So these three things are really important to know, and to know that they are the major signs or whatever of an increase in intracranial pressure. Don't miss those. They are very likely to come up on an exam. We talked about Cheyne-Stokes respirations. I put these here just because people struggle with, like, especially the difference between Kussmaul and Cheyne-Stokes. In Cheyne-Stokes breathing, because sometimes the questions won't say Cheyne-Stokes, they'll describe the breathing, and you're just supposed to know what it is, right? Cheyne-Stokes will go, breathing gets deeper and deeper. Every breath gets deeper than the one before. Then they become shallower, 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 and then you have this period of apnea with no breaths. And then it repeats again, okay? Cheyne-Stokes is usually, I think people call it like the death rattle. Like, this one's indicative of something very, very, very serious going on. And we'll talk about Kussmaul breathing when we talk about diabetes and diabetic ketoacidosis. For this unit, it's all about the Cheyne-Stokes, okay? And then your decorticate and decerebate posturing. This is, if you look at the GCS, right here, you see down here abnormal flexion and abnormal extension. One is called decorticate, one is called decerebate. I'll leave it to you for how to memorize that. I can tell you what I did, but it might not work, because in my study group, we had a girl named Sarah, and sorry, I can't write with this thing, forget it. Anyway, this is Sarah. And we were having the hardest time just like remembering which was decorticate and which was decerebate, because they would describe it. Your arms are in, your toes are pointed, or your arms are pointing out, and right? And she was like, "Are you Sarah?" And I was like, "No, my name's Lauren." She's like, "Point to Sarah." So I pointed at her, and she's like, "Yeah, you're pointing away from yourself. If you point to Sarah, away from yourself." And then she's like, "So that's decerebate." And that is the most stupid, ridiculous thing. But I'll tell you what, I never, ever got them mixed up again after that. So please don't judge me for that. It's the dumbest thing ever, but it worked. And a lot of this stuff, you just have to find a way to make it like memorable for you. That worked for me. I'm not Sarah, so Sarah's away. It's ridiculous. So after that, this is kind of like, how do we manage ICP? What are we going to do? And we talked a little bit about this already. Because of that relationship between your mean arterial pressure and your intracranial pressure, and what we're trying to keep above 70 is this cerebral perfusion pressure that's in between. So if your intracranial pressure rises, you're going to lose some of that cerebral pressure that's in the middle. If your mean arterial pressure lowers, you're also losing some of that, right? So what do? We want to, our concern is this cerebral perfusion pressure, because that is what's going to stop, that's the pressure we need to get the blood to the brain. So as that lowers, the amount and the pressure of blood that's going into the brain is getting lower and lower and lower. And we talked about what happens when that gets under 50 and 40, right? The brain becomes ischemic, and then you've got that whole ischemic kind of cascade that starts, and then you're in big trouble. So we want to keep the O2 sats around 90 to 100. They don't need to be like 95 to 100. Part of that is, so when your oxygen is going up, right, and you're getting lots of oxygen, your O2 sat is high, you're expelling a lot of CO2. And so we want to make sure that, so CO2 is a very, very potent vasodilator. Oh, I don't know how this happened. So it's going to, it would decrease your blood pressure and your mean arterial pressure, right? So again, if you look at this little scribble that we did over here, if that mean arterial pressure is dropping, we're actually losing some of this central perfusion pressure. So we want to be very, very careful about the amount of O2 that we're allowing to stay in the body. So what we used to do, and what a lot of people still do, I think in your slides it said it was like an old method, but I still see this done all the time, is hyperventilating. And that's because the more oxygen you're getting in, the more CO2 you're blowing off. And the more CO2 you're blowing off, the less chance you have of this vasodilation effect that's going to bring your blood pressure down and bring your cerebral or your MAP down and close that cerebral perfusion pressure. So you just need to kind of understand that the way that works. I did have questions about that on my exam. I don't know if you will, but just kind of understanding. Oh, Kieran can probably tell you if that's something you need to worry about, but understanding that relationship between CO2 and blood pressure and MAP is really, really important regardless.
Yes, I would say that is important because that comes up a lot for a lot of things, especially after this as well, how CO2 has an effect on your blood pressure.
Yes. Yeah, so just make sure you kind of understand this. Well, I'm going to leave it at that. CO2, potent vasodilator, and you should be able to go from there. We want to keep our CPP between 70 and 100. Again, that might involve allowing our blood pressure to remain a little bit higher than normal. And that's because we don't want to close this gap between the intracranial pressure and the MAP. Again, treatment, often mannitol or a hypertonic solution. That's because just even if you have increase in ICP, for most of the time, regardless of what that increase is, we need to get that ICP down. Because again, if it gets higher, we're closing this off, right? So you will often give mannitol or hypertonic solution to pull some of the extracellular fluid from the brain tissue, because that will make the brain tissue shrink a little bit, and that will keep your intracranial pressure down. There are these kind of meds that kind of go along with this kind of treatment. So sometimes we'll give anti-seizure meds if the patient's at risk for seizing, corticosteroids to bring down an inflammatory response, stool softeners so that we don't have an increase in intra-abdominal pressure, because that will affect your intracranial pressure. And then this is really important. One of the things that, so for repair of any kind of trauma, brain trauma, whatever, we have to have the nutrition that we get from food. And so very, very quickly, you'll see somebody being hooked up to, I can't talk today. I don't know what that is. Parenteral nutrition, sorry. Because we need those nutrients. It's really, really important part of treating a drop in ICP, okay? So those are really like the main the main things that we're concerned with. There's a couple other little tricky things that they might talk about. I find this elevating the head of the bed comes up a lot. When would we do that? If a patient has increased intracranial pressure, what will happen? So if you sit the patient up, gravity will do its job. Some of the blood will come down, right? It will increase that venous return to the heart. So it's going to decrease blood volume, and it's going to bring some of that ICP down. Clinical pearls, I'm not really sure what that is, but so basically, if you can't sit the person up, because we do this, if you can't sit the person up because we haven't cleared their C-spine yet, they've been in a car accident or whatever, and there's no way to know that their C-spine, basically, we have to know if we move them, we're not going to be causing any further damage. So if we can't sit them up, you can put them in reverse trend. So it would be with your head down and your legs up. Sorry, reverse trend, that's trend, sorry. My brain. Reverse trend would be basically leaning down like this in the bed. So you kind of actually move the bed so that the head is up, but their body position doesn't change. And that way you can get some of that increase in venous return. And again, we talked about mannitol and what mannitol does, right? It's going to decrease the brain volume because it's pulling out some of that extracellular fluid. Of course, we're not going to give that to someone who already, this hypertensive or hypertonic solution, you're not going to give that to someone who's already hypernatremic. You guys can put that together. Here, honestly, you're going to use mannitol if you need to use mannitol when they're anywhere in that window. Can cause volume depletion. Yes, this just makes sense. They're not really giving you anything huge here. You can walk this through. If I'm going to pull fluid out of the extracellular space and pull it into the vascular space, and then I'm going to diurese it through the kidneys, it may cause hypotension and fluid volume depletion. It can also cause fluid volume excess, depending on how much of that fluid is taken back up in the kidneys or how well the kidneys are working. So you have to watch whenever you play with somebody's fluids, you just always have to watch for both fluid volume excess, fluid volume depletion, and any kind of huge electrolyte imbalance. But that's all stuff that you, I think, can put together. I don't think that's a huge. How do we monitor ICP? They do this thing called a ventriculostomy. Usually the I don't know which one of them. I think it's the subarachnoid. These are all different methods. It doesn't really matter. Basically, they're putting like a probe somewhere into the brain to monitor that pressure. And you can put it in the subdural space. You can put it right in one of the ventricles of the brain. You can put it in the subarachnoid space, right? There's all these kind of different epidural space is probably less invasive. Like so this is an ICU thing. Like it's not something we necessarily would do, but knowing that this is how we would measure it is a good thing to know. And then these are just knowing the difference between absolute brain death and a persistent vegetative state. When you have brain death, all brain function stops, including your brain stem. And you know that your brain stem is where your autonomic nervous system is. So that's what's causing you to breathe and your heart to beat all on its own, right? So when there isn't evidence of brain stem function, so usually at this point the patient is on a ventilator, so even though their brain stem has stopped functioning, the machine is still making sure that oxygen is going in, glucose is going in, and everything is coming out and going in the way it should, right? Breaths are going in, whatever. After 24 hours without evidence of that brain stem function, then we can officially call the patient brain dead, or they've experienced brain death. So that basically if you did quote unquote unplug the machines or whatever, the patient would pass on their own. They obviously can't maintain adequate blood pressure. You'll see profound bradycardia, and then definitely a loss of basic neurological function, right? You're going to see a lot of this stuff over here in the persistent vegetative state as well. Really, the big difference is that the brainstem is spared. So the gray and white matter is severely damaged. So their ability to think, their awareness of their self, all of those kinds of things are gone, but their reflexive functions are still there. So breathing, sleep-wake cycles. So they'll have that spontaneous eye, may have that spontaneous eye opening. Bladder and bowel are still working, but they can't control them, so they'll be incontinent. They'll have to have enteral nutrition or parenteral nutrition. That should be parenteral, not enteral. And then need for full nursing care. And really the difference here is that brainstem. When the brainstem has stopped or has been damaged and to the point where it's not working, we're going to call that, that's going to be brain death. When the brainstem is spared, it's still working, but everything else has been damaged to the point where everything that makes that person a person is basically gone, but they will still live on. We would call that a vegetative state. So I think we hit, oh yeah, see, there's remembering that this is a potent, CO2 is a potent vasodilator. Very, very important. Anyway, I think we've gone over everything quite a number of times. We've said all the norms at least 100 times, so I think you guys should be good. Is there anything that you're confused about or any questions that you have? Before we go, kind of just going over to look at what we talked about in case we missed anything. Nope. No, this is your big important thing, which I think we have that down now. This Cushing's triad, make sure you, I know I said it already, but make sure you have that. Kieran, was there anything on a diffuse axonal injury?
Briefly, like I have a small note about it, but not much on that. I think you covered most of it.
Okay, so it's not a big deal. Yeah. Really, so I've hit everything that you, is there anything I missed that you can, that you see?
No, I think you did everything. I just remember there being a big focus on the Cushing's triad.
Okay.
Oh, there's a question.
No, go ahead, Karen. It's okay, I'll do that one after.
But yeah, there's a thing on Cushing's triad that you went over, which was good, because I remember the prof giving us kind of like a simplified process of it. Like you have the TBI, and then you have the edema or the bleeding that comes, and then you have the Cushing's triad because the body's trying to, compensate, and then so just knowing how that leads to the ischemia and everything. So that's good. I think we're good with that. And the coop and contra coop is also important.
Right here. Okay, and so this right here, just so you know, this Cushing's triad though is sign of an increase in intracranial pressure. That's what that's telling you, just so you know. That's the sign. Sorry, there was a question. A sub and epidural hemorrhage versus a hematoma. So what's the difference? Sorry, somebody's asking what's the difference between a subdural or epidural hematoma and a subdural or epidermal hemorrhage. And that's really simple. The difference is that in a hematoma, if you look here, the blood, there is a bleed, but the blood pools in kind of one small area. Have you ever seen a hematoma in real life? If you've ever seen, even if sometimes it happens when you take out an IV, take out the IV and there's like a little bubble of blood, right? It's that kind of thing. It's a blood bubble. Whereas the hemorrhage is a loose kind of brain, where is it? it's this way. Oh, we didn't go over hydrocephalus. The hemorrhage is like a loose brain bleed. So it's bleeding. So here, subdural hematoma. It's not just a pocket of blood that has grown, like a little pocket or a bubble or whatever. It's bleeding. It's bleeding out into the space, into the intracranial space, and further. Does that make sense, Darla? If it doesn't, that's okay. I can explain it better if you need to, but hopefully that. Would the onset be different? Nope. You could have an intracranial bleed. So a hemorrhage could be a result of like an injury, like an actual outward injury, like hitting your head. It can also be a result of a stroke, right? A hemorrhagic stroke. And then a hematoma would be mostly just the injury, right? Like you've hit your head. It's almost like a giant, I don't want to say bruise and confuse, but like a giant pocket of blood instead of that like active bleed that's happening, if that makes sense. But there's not really a huge difference in onset, right? It's going to be you're going to have the similar symptoms of the level of consciousness is going to, like how I hit on that 300 times, your level of consciousness is going to decrease. You may see, depending on where the hematoma or the bleed is, you may see different things, like different, like a dilated pupil on one side and not on the other, and so on. But you don't have to know all of that for this test. You just kind of have to understand the difference. I don't think there's anything special. At least there wasn't anything in your slides or in the book that was like special for you to determine the difference from the outside. You have to get a scan to really see that. There isn't a whole lot that's going to like separate. I mean, there is, but you don't need to know those little details. Did you guys not include hydrocephalus at all in your notes? Because I won't go over it if we don't have to. Kieran, I know you did. I know it was in yours, but yeah, see, they didn't hit on it. Okay, so I'm not going to go over it then, because I think it'll just confuse. Was there anything else you guys wanted to go over? Or Kieran, anything else you want to add? Did I miss?
No, I'm just looking at my notes right now. And I'm just looking at the hematoma part, I know we kind of, well, for us, we went over the epidural and subdural, and the way that we kind of differentiated one was a tear in an artery, and one was the tear in the small bridging vein.
Yeah,
so
yeah.
That's how she told us to kind of like differentiate it, and like that's how specified it. That's why, I don't know, I just wanted to add that in. But
yeah, no, that's good. I wouldn't go, because your notes didn't include, like, they didn't go into as much detail as last semester's, which I think is good. It's a lot to remember. Don't go crazy. Just make sure you understand the basic concepts of what's happening in a hematoma. It's that pool, the blood pooling, and Kieran's right. It's going to pool differently depending on where that kind of break or injury in the vascular system happened, right? But I don't think you wouldn't be able to identify that from the outside anyway. So there's no like question they could ask you like, oh, the patient has this, this, and this, and you can identify that it's specifically an epidural hematoma. At least not with what we know, and without like diagnostic, like imaging and stuff. I did want to go over this. You guys didn't talk about the reticular activating system at all, because I'm not going to add to your stress if briefly. Oh, she did mention it, because it's going to come up. Just know, all you really need to know about the reticular activating system is that it's really responsible for your like arousal and awakeness kind of, or wakefulness kind of thing, right? So a lot of your level of consciousness, I don't really know how to. Kieran, how much can you explain about the reticular activating system other than that?
That's basically it, though. Like,
Okay.
nothing else, because it's not very, yeah, it's just wakefulness, and it just keeps you, I guess.
So I guess knowing maybe if there's a question that's like, they're having a hard time staying awake or whatever, what part of their brain may be damaged. Just knowing that the reticular activating system is in the brainstem. And that's what it's kind of one of the big things it's responsible for. Just so you could answer a question if they ask you something like that. But I don't think there's much else. That's good, Kieran, because I was like, am I forgetting?
No, she just,
Like,
my prof just literally like said one sentence about it in the beginning, and then that was it.
Good. Okay. So we're not going to go any further into that then. Any other questions, guys? If not, I think we will head out. Kieran is going to take over next week and do the renal stuff for you guys. Yeah. What are you going to do, a mind map again, Kieran?
Yeah, I'm working on it.
On the spot.
I'm looking at videos again just to follow the information.
I'll refresh your mind. Let me just turn the recording off so we're not recording.